Welcome to AETCM, the emergency medicine channel. Starts. A 32-year-old female presented to ER with complaints of fever associated with headache since last 3 days. Also, she had complaints of difficulty articulating words and memory impairment since last 1 day. On initial 10-second assessment, patient is conscious but not oriented to time, place and person. Airway pattern, no pooling of secretions. Coming to breathing, respiratory rate was 12 breaths per minute and SpO2 was 98% on room air. Air entry was bilaterally equal. Coming to disability, GCS was E4, V4, M6. Pupils bilaterally equally reacting. Exposure temperature was 98.7 degree Fahrenheit. Adjuvants to primary survey, we got a CBC CRP done which showed a total counts of 7.9, HB 10, platelet was 238,000, CRP was 50. VBG, no electrolytic imbalances, no acidosis or alkalosis. ECG showed sinus tachycardia. Coming to sample history, a 32-year-old female, gravida 2, para 2, 4 months postpartum, presented to ER with complaints of high-grade intermittent fever associated with headache since last 3 days. She also had a history of memory disturbances in the form of forgetfulness, difficulty recalling recent events, episodes of confusion, difficulty articulating words since 1 day. No history of facial deviation, slurring of speech, blurring of vision, seizures, recent fall or trauma. No history of any complications during pregnancy or delivery. No history of instrumentation during delivery. Patient did not have any history of dysuria, loose stools, cough or vomiting, and no prior psychiatric illness. With initial investigation and history, we had a differential diagnosis of either it can be postpartum depression or meningitis. This depression can be seen in patient postpartum till 1 year of postpartum. But then
postpartum psychosis, no, not depression.
Postpartum
psychosis. They can have both depression, anxiety, fear. So many things can be there.
Then we had both meningitis and postpartum depression as the initial differential DDs. So we had sent the patient for MRI brain with contrast. Meanwhile, we had done a systemic examination. CNA, coming to CNS examination, GCS was E4, V4, M6. Patient was confused. There was no neck stiffness. Kernick sign and Brudzinski sign was negative. Motor examination power was 5/5 in all 4 limbs. Cerebellar signs were negative and patient did not have any ataxia. Coming to CVS, both S1, S2 heard. Then initially we had got ejection systolic murmur in the second intercostal space and pansystolic murmur in the apex. Coming to RS, air entry was bilaterally and equal. Coming to abdomen soft.
What are the differential diagnosis for an ejection systolic murmur in aortic area?
Any obstruction causing, so it can be a...
What are the DDs? MBBS question. It's only an MBBS question.
Anemia also can cause...
okay, anemia. She is having
hyperthyroidism.
Hyperdynamic circulation. Okay. Hyperthyroidism is anemia, thyrotoxicosis, beriberi, everything comes there.
AS also.
AS. Then
vegetation obstructing or...
okay, AS or aortic valve obstruction due to vegetation. Okay. Infective endocarditis. Then HOCM. Then hypertension. Everyday we are seeing case. Hypertension. AR. AR itself can produce an ejection systolic murmur. AR normally producing early diastolic murmur. If the flow is more during the systole, it will produce ejection systolic murmur. So how do you differentiate AS from all other conditions? AS from hypertensive heart disease or you told infective endocarditis, whatever it is. AS means is valve is stenosed. AR itself can produce an ejection systolic murmur. Hypertension can produce. Old age can produce aortic sclerosis and ejection systolic murmur.
LVH.
LVH. Okay. Then AS and clinical
cardiomegaly.
Peripheral clinical finding. Pulse will be
Pulse.
pulse will be pulse will be low
Low
volume,
volume
BP will be
BP,
systolic
systolic.
decapitation. These are the two important signs of isolated AS.
Yes.
But AR is there, then the clinical findings will vary. Hypertension, that also vary. So everything will be different. Only thing which is near to AS is HOCM. Okay. HOCM can also have low volume pulse, low systolic BP. That is that will be HOCM will be dynamic obstruction. What is dynamic obstruction?
If the workload increases, then
When the patient
workload.
exerts, that lesion increases. Okay.
So we got an MRI brain with contrast done, which showed T2 flare hyperintensities with diffusion restriction in the left gangliocapsular region, causing mild mass effect, and history of multiple tiny punctate foci in the right gangliocapsular region. So initial DDs were either subacute infarcts with small hemorrhagic foci, embolic events, or focal cerebritis.
Okay.
Since we had gotten new onset murmur.
There are multiple infarcts now. It is
Yes.
not focal cerebritis. It is only a shower of
Shower
emboli
of
from
emboli.
somewhere, whether it is carotid or heart, we don't know.
Yes. Bedside echo and 2D echo was also done, which showed a mobile echogenic vegetation attached to the aortic wall measuring 10 into 6 mm with acute severe AR. But patient did not have any features of acute AR. Sir. There was no pulmonary edema, no hypotension, no palpitation. And also had a mobile vegetation attached to the mitral wall measuring 9 into 3 mm with moderate to severe MR. Then now from all the clinical investigations, we came to a conclusion that patient is having infective endocarditis. So a blood culture of infective endocarditis protocol was also sent. And patient was initiated on both ceftriaxone. Initially, we were suspecting meningitis, so initiated on ceftriaxone 2 gram IV that, and also was initiated on Dexa for 8 mg IV. Then we also initiated on injection vancomycin.
Okay. So you have to give steroid much prior to your antibiotic. That you have to give. Then ceftriaxone 2 gram IV
every 8 hourly.
8 hourly. Then
Vancomycin.
Vancomycin. These are 3 things you have to give first. Mannitol, should we give mannitol here?
Yes.
Yes or no? Cerebral edema, no. Is there any cerebral edema? So it is not going to help you. Steroid?
Steroid
we
is
are given.
required.
Steroid is given. Mannitol is avoided. Okay.
Coming to the European Cardiac Association new guidelines regarding infective.
LP, what happened? That also you have to tell.
LP and culture report came today, a provisional report only, sir. Gram positive cocci.
Gram positive. Okay.
They
It's
have
a
not
common
mentioned.
organism which produces infective endocarditis meningitis.
Then we got a history that patient had a dental procedure done in November
that
6th.
May be the reason. But basically, this patient might have had a pre-existing cardiac lesion. That's why she had developed an infective endocarditis.
So according to the new guidelines, there are certain recommendations from previous 2015 guidelines. This is 2023 guidelines. When it comes to prevention, in patients who are more susceptible to infective endocarditis, recommendation for antibiotic prophylaxis in patient with cardiovascular disease undergoing orodental procedures at are increased risk of infective endocarditis. It was initially should be considered, but now it is indicated.
Okay.
So now it is indicated in patients with previous infective endocarditis, in patients with surgically implanted prosthetic valves, in patients with transcatheter implanted aortic or pulmonary valvular prosthesis, and also should be considered in patient with mitral and tricuspid valve repair. Antibiotic prophylaxis recommended in patient with untreated cyanotic congenital heart disease or patient with treated congenital heart disease containing a transcatheter procedure or postoperative shunt or conduits or other prosthesis. Antibiotic prophylaxis include it should be given 30 to 60 minutes before the procedure. If the patient does not have any allergy to penicillin, we can give amoxicillin, ampicillin or ceftriaxone. Amoxicillin 2 gram orally, ceftriaxone 1 gram IV can be given. If allergic to penicillin, then we can give cephalaxin 2 gram orally, azithromycin 500 mg orally, or doxy 100 mg orally, doxycycline 100 mg orally. Then coming to clinical features of infective endocarditis are highly variable. It can be acute, subacute or chronic. Should be suspected in a patient with sepsis without any obvious sources, and also in pyrexia of unknown origin without, plus patient having some underlying risk factors. It can be either cardiac or non-cardiac. Cardiac risk factors involve previous infective endocarditis, valvular heart disease, prosthetic heart valve, central catheter, transvenous implantable cardiac devices, or congenital heart disease. Non-cardiac risk factors include central line, people who are injecting drugs, immunosuppression, recent surgical procedure, or patient undergoing hemodialysis. So now we have a modified diagnostic criteria for infective endocarditis. They have made certain changes in major and minor
What is that criteria called as?
modified Duke's.
Duke's.
Major contains blood culture, typical microorganism consistent with infective endocarditis with two separate blood cultures. Typical organisms include streptococci, S. bovis, Hasselt group, Staphylococcus aureus and Enterococcus faecalis, or microorganism consistent with infective endocarditis with continuously positive blood culture for more than two positive blood culture.
Here all the 5 samples are positive.
Yes, sir. And which was taken within 12 hours apart, okay. Or all 3 or more than 4 blood culture which was sent to us positive. Then also if the blood culture is positive for C. burnetii. Then imaging then second major criteria is imaging positive for IE. They have also, initially it was echo and cardiac CT, now they have all included PET CT and photon emission topography also.
TE also.
Yes, sir. Yes, sir. In new recommendation, TE is
most of the time we may not visualize the clot or this vegetation. TE can pick up.
Yes. And then minor criteria include predisposing conditions like we discussed before, fever more than 38 degrees Celsius, embolic vascular dissemination, patient having mycotic aneurysm, major system or
mycotic aneurysm.
There is weakness in the walls, in the walls of the arteries because of this infection causing pseudoaneurysm.
Doesn't mean that it's a fungus.
Fungus, no sir. Most commonly caused by bacteria. If patient is having intracranial lesion, hemorrhagic lesions, conjunctival hemorrhages, Janvi lesions. Then immunological phenomena include glomerulonephritis, Osler's knots, rod spots and rheumatic fever. Then microbiological evidences, positive blood culture that does not include whatever we discussed in the major criteria. So definitive if we have a 2 major criteria or 1 major plus 3 minor criteria or 5 minor criteria. Possible if the patient is having 1 major plus 1 or 2 minor or 3 to 4 minor. Rejected if the above is not fulfilling. Then recommendation.
The role of heparin, anywhere it is described that this patient is having infective endocarditis with multiple shower of emboli. Is it recommended anywhere about heparin?
Already does not require. Already if the patient is taking any antiplatelets or anticoagulants, then if the patient is having any hemorrhagic transformation, then we are supposed to stop.
Okay.
Recommendations for echo, like you told, transesophageal echo is actually recommended in suspected IE. Even if we take transthoracic, we are supposed to get
not visualizing the lesion, then you have to go for
but in the recommendation they have mentioned, if you are visualizing or not visualizing, you are supposed to get a transesophageal.
That is better.
Yeah. Then indications for surgery in infective endocarditis. There are two types of indication: emergency indication and urgent surgery. Emergency surgery is indicated if the patient is having a vegetation more than 10 mm with acute AR, acute MR leading to hypotension and pulmonary edema. Then emergency. Urgent is required if the patient is having persistent infection in the form of if the patient is having any abscess or shower of emboli.
Should this patient go for emergency surgery or elective surgery?
Here the patient is not having symptoms, but she is having 10 mm vegetation with acute.
She may require surgery, but not immediate.
Yes,
immediate means in ER we no need to refer for surgery.
Yes, sir. Then patient urgent surgery, abscess, fistula, or if there is enlarging of vegetation, or if the patient is having high risk for embolism or embolic shower. Then recommendations for previous 2015 criteria, this was considered, not recommended. I mean, all these surgery indications to be considered. Here it is indicated. Then recommendation for the treatment of neurological complications of IE, brain CT or MRI in patient with IE and suspected infective cerebral aneurysm has to be got. Or if you are not finding any findings in the MRI or CT, and if you have a strong suspicion, like our patient had memory deficits, and then we have to go for an invasive angiogram. This is also indicated now. Previously it was just recommended, now it is indicated. Then recommendation for IE related to implanted electron devices, antibiotic prophylaxis for S. aureus and S. bovis is now indicated. Then also we have to get a transesophageal or transthoracic echo if you are suspecting an infective endocarditis in these patients. Then in case of catheter-related infective endocarditis with bacteremia or fungemia, we have to make sure that we are continuing the antibiotics since all the blood cultures and procal becomes negative. Then recommendation for surgical treatment of right-sided infective endocarditis. Surgery is indicated in following scenarios.
Right-sided endocarditis is commonly seen in which type of patients?
Congenital heart disease.
It is a common scenario now. What is that scenario?
IV drug abuse.
IV drug abuse. IV drug abusers are more prone for right-sided infective endocarditis. Like you told, congenital heart disease can have any area they can have.
Okay, sir. Right ventricular dysfunction secondary to acute severe tricuspid regurgitation, or a patient having vegetation with respiratory insufficiency requiring mechanical ventilation, or large residual tricuspid vegetation more than 20 mm, then surgery is indicated. Then recommendation for the use of antithrombotic therapy in IE. Interruption of antiplatelet anticoagulation therapy is recommended in case of major bleedings. Then phase of antibiotic treatment, we have two phases: early critical phase and continuation phase. In early critical phase, patient should be treated with rapid bactericidal agents. With if cardiac surgery is indicated, then cardiac surgery is recommended. Then if there is any infection of the implantable device, then removal has to be done, and draining of any abscess has to be done in the early critical phase. In continuation phase, if the patient is complicated, like patient is having any embolic phenomenon or all of that, then we have to continue the IV treatment. If the patient is actually stable, then from day 10 of initiation, we can continue with outpatient IV treatment.
How long we have to continue the treatment?
Depending on the organism. Prosthetic valve always more than 6 weeks. Other things, native valve, depending on the organisms we have. And when it comes to empirical antibiotics, if the patient is having native valve endocarditis or late prosthetic valve endocarditis, then we can initiate on ampicillin 12 gram IV 1 day. It can be given in 4 to 6 doses. Ceftriaxone 4 gram per day can be given in 2 doses. In patient with early prosthetic valve infective endocarditis or healthcare associated infective endocarditis, then we have to give vancomycin 30 mg per kg per day, or daptomycin 40 mg per kg per day in single dose.
That is only after getting a culture report.
Empirically,
how do you select? You are told already.
yes, sir. Empirically, I told. Now, once we get the culture, if we get the streptococcus or streptococcus bovis, then initial treatment, if there is.
Here, you have to select 1 gram positive coverage, 1 gram negative. Like meningitis. Always to select a good gram negative, good gram positive, including one will be vancomycin.
Okay, sir. If then we once we get the blood culture, if we get oral streptococcus or streptococcus bovis, then we have to give, if there is no complication, 4 weeks of treatment. We can give either penicillin G 12 to 18 million international unit, 4 to 6 doses, amoxicillin 12 gram per day, 4 to 6 doses, ceftriaxone 2 gram per day, 1 dose. If the patient is allergic to beta-lactam, vancomycin has to be given 30 mg per kg, 2 doses. And if it is due to staphylococcus, then we have to, if the patient is methicillin susceptible, 4 to 6 weeks. If methicillin resistant, then more than 6 weeks has to be given. Methicillin susceptible, we can give flucloxacillin or cefazolin. If it is methicillin resistant, vancomycin only. So then Enterococcus faecalis species angle 4 to 6 weeks has to be given. If they are beta-lactam susceptible, then we can give amoxicillin and ampicillin. If beta-lactam resistant, vancomycin. If vancomycin resistant, then daptomycin has to be given. If blood culture negative infective endocarditis like Brucellosis species, we have to give doxy 200 mg plus rifampicin plus cotrimoxazole for 3 to 6 weeks. All blood culture negative for infective endocarditis, 4 to 6 weeks treatment has to be given.
Anything else? What are the high risk? You should also read about high risk lesions and low risk lesions. Most of the lesions, this patient is having high risk lesions.
Yes.
What are low risk lesions? Low risk lesions. That means they are in
Vegetation is not causing any valvular.
They don't develop infective endocarditis. They are immune to infective endocarditis. What are these lesions? Tell 2 lesions which are immune to infective endocarditis. That means you can just avoid infective endocarditis prophylaxis even if you do a procedure in your patient. What are the 2 lesions?
Aortic stenosis.
Aortic stenosis is a high risk lesion. AST and MS. Why? Rest all lesions are producing a turbulence in the heart, whether it is aortic stenosis, aortic regurgitation, mitral regurgitation, tricuspid regurgitation, tricuspid stenosis. Or tricuspid stenosis is less this one. So they all produce a turbulence and they produce wall damage because of the turbulence. So they are all AST is immune, but VST is highly risky lesion. So whenever you are doing any procedure in a patient in emergency room, whether it is catheterization or central line, and oral procedures we do in dental, we have to see the risk of the patient. So this patient is a high risk patient, but unfortunately it was not noticed during the procedure what was done. She might not have complained about that, or there is no previous history.
Yes.
That may be the reason. Okay.
Thank you.